Well, it's great to actually get the opportunity to chat to fitness guys again. It's been a little while. I'm kind of getting dragged all over the place at the moment, working for pharmaceutical companies, redesigning new shoes, sharing and liking everybody's Facebook stuff. It's a full-time job just doing Jenny's, never mind anybody else's.
That's right. If it's not Facebook, it didn't happen.
Exactly. So so it's great to get the opportunity to come and chat to you guys. So thanks, Rach. So the context around today is going to be around knee mechanics, and particularly we're going to be talking about ligaments. We're going to be talking about how you can screen ligaments. Those biomechanics coaches amongst us will know the sort of functional dynamic tests, ligament dominant, quad dominant, leg dominant, that kind of stuff. What we're interested in today is more specifically looking at the knee and looking at different ligament tests that we can do. Now, ligament tests have typically been the domain of medical people to try and diagnose whether you've got a cruciate ligament injury or whether you've got a lateral ligament injury or something like this. The test to identify whether the ligament is loose or lax is exactly the same as the test to identify whether you've damaged it. The context is simply different. So the tests are going to be the same, but we're just going to apply it slightly differently. This is not a way of you being able to diagnose whether someone's got an ACL injury or an MCL injury. It's all about, is that ligament able to provide what it's supposed to provide? Does it have the capacity to do what a ligament should do? That's as simple as we're going to do. So my question to you guys is, what should ligaments do? What is the purpose of ligaments? You didn't really think I was just going to come in and tell you the answer. What do ligaments do? What's the function? Sorry?
Bone to bone.
Yeah, it is bone to bone, and typically its function is to do what? Yeah, stabilise the joint to prevent the bones going out of their alignment, so to speak. Correct. What else is there? Key function. Probably more important function, actually. You'll see why I did not get any art qualifications now. That is not a tree or a cauliflower, that is a brain. Honest. That's a knee, looking at it from the side. And although we'll go into the anatomy in a bit more detail in a minute, that's your anterior cruciate ligament. That's as much of a clue as you're going to get. What are the other key functions of ligaments?
That's not the shear force, isn't it? Before going outside of the
Yeah, make sure those bones stay in relative alignment.
Proprioception.
Yes, absolutely. You're familiar with proprioception. Proprioception, in simple terms that I understand, proprioceptive cells are like little strain gauges that sit in the ligaments and the joints and the capsules and so on. And basically they talk to the brain, send information to the brain saying, oi, I'm being stretched, the tibia is being taken too far forward. They then fire information down to the muscles to counter the movement. So proprioceptively, they have a really, really important role. The problem, of course, if that ligament is too loose and allows too much movement, then it's going to take longer before that proprioceptive stimulus is created, which means that the joint is more vulnerable before those muscles can engage. So it's a critical proprioceptive function. Proprioception is a critical function as well as trying to make sure the integrity of the joint is maintained. So there's two key functions. Let's just talk quickly about the types of evaluation. There's loads of different evaluations that we can do. We've got a clinical examination to try and identify whether a ligament in this context is damaged. We've got a movement screening, which we're all kind of familiar with. There's lots of different types of movement screenings out there, and they're all much of a muchness, but they're all trying to do a similar thing, which is great. And then, of course, we've got the intrinsic biomechanical screening as well. So the clinical examination, you might suggest, is what the problem is. The movement screening evaluation is how have they created that problem, how's that problem manifested itself, what's caused it. But the intrinsic biomechanical screening looks at why. And it's a combination of all of those factors. All of those screenings are important to try and understand the cause of that knee injury and actually what we're going to do about it. So it's not suggesting for one moment that the movement screen is more important than the biomechanical one or vice versa, or the clinical examination. They're all linked together. They all have a value and they should all be integrated together. Does that make sense? Yeah? Okay, so the ligaments we're going to look at, medial collateral, lateral collateral, anterior cruciate and posterior cruciate. Those are the key. There are more ligaments in the knee, but we've got 40 minutes, so we're just going to concentrate on those guys. Let's just go through a little bit of the anatomy. You'll know this basically, but let's just make sure we're all on the same page. Now this got a voice, an audio to it, but the audio is not working very well, so you have to put up with me. So you're familiar with the basic ligaments, PCL, MCL, ACL and LCL. And this is quite a neat graphic just explaining and just showing, just turn that around. So we've got the lateral ligaments either side, which you can see here, and they're designed to stop or limit lateral movement, valgus and varus movements of the knee. In a moment, the patellar tendon is going to disappear, and that's going to show us the anterior cruciate ligament, which comes from the front of the tibial plateau to go back up to the posterior part of the lateral femoral condyle, and the PCL goes from the back of the tibia towards the medial femoral condyle. In a moment, we'll talk about the movements that these ligaments are trying to limit. The anterior cruciate limits that anterior translation. It will also have a role to play in the rotation component as well, in terms of limiting that. And the PCL will help to limit more of the posterior translation. If you don't have an anterior cruciate ligament, the tibia is more likely to translate anteriorly. If you don't have a posterior cruciate ligament, it's more likely to rotate posteriorly, or translate posteriorly. The video now is going to talk about ACL reconstructions, which we're not really interested in now, but when we send you the PowerPoint presentation, the next bit of it goes on to talk about a bone tendon, bone cruciate ligament replacement, which is quite interesting. So let's just move on. You familiar with that stuff? It's just a refresher really, just to remind you really. So, medial ligament, let's look at the anatomy, let's look at the screen, let's look at the muscles involved that relate to that medial compartment, and then let's have a look at some exercises that you might create to try and help those people with medial ligament deficiencies, laxity. So a little bit more detail on the anatomy. That's looking at the inside of the knee, that's the femur, that's the patella, medial femoral condyle, that's the tibia in here. When I first went to college, I kind of figured that the medial ligament was like a little band that ran down the inside of the knee. And it kind of is, because there's a thicker bit in here. But you can see it's actually quite a massive ligament. It covers a lot of that medial compartment. So it's not just like a straw that goes down the inside of the knee, which I certainly thought it was initially. So it's quite a large band of material on the inside there, trying to limit the amount that knee will go into valgus. In other words, how that tibia is taken out to the side compared to the femur. So that's the anatomy. There are different ways of screening. I'm going to show you the screen on here. This guy's going to do a screen for us and shows how to do that collateral ligament screen, and then I'm going to do it here on one of you guys. So think about whether you've got an MCL, a medial ligament that's loose, so everyone can see it. So basically you get hold of the tibia and make sure it's fixed, and the idea is that you move the tibia laterally and medially, valgus and varus, with the knee in a slight degree of flexion. So that knee needs to be about 15-20 degrees worth of flexion, otherwise the anterior cruciates will just lock the knee into position, and then you laterally move the tibia and the tibia on the femur. So here he's going to look at the lateral ligament where he's going to push his hand in towards the knee. It's maybe not the best angle to see, but the knee is gapping there on the outside. And from this angle he's now going to do the opposite. So he's going to now push medially towards the knee, and the laxity of the medial ligament will be demonstrated as the joint gaps and the tibia moves in a valgus position. And in a minute he's going to turn, he's going to push that leg across. So that's basically how to do a medial collateral ligament and a lateral collateral ligament test to identify whether it's loose or not. Should we have a practice? Who would like to volunteer? Preferably somebody with shorts on.
Well, I've got shorts on, but I want to do it.
Come on. You can roll those up, right?
I will.
Fantastic. You can do whatever you like.
Shows off.
If we, yes, if you would like, this angle here, just you lie down. But head at the other end, please. So, what's your name again?
Fiona.
Fiona. So, which is the loose one, do you know? The left one. Fantastic.
I've got one. Maybe meniscus. I've got an issue with just don't know where it is.
Right. Would you like to lie down? So remember, we're not going to diagnose this. We're not going to say to you, you've damaged your medial ligament. All we're interested in is whether that medial ligament is loose. Because if it's loose, it's going to compromise the stability of the joint, and you probably want to know about that when you're prescribing exercises. And then you're going to want to know which exercise is the most appropriate, which is the next piece. So, the idea is once you've relaxed your client and done all the sort of obvious stuff that you guys know, take hold of the tibia, and then we're looking to have the knee flexed to about 10-15 degrees, so we're into here. That takes the tension off the cruciate ligaments, which means that any valgus load is one where the tibia is taken out to the side, will identify any laxity in that ligament. I'm just going to use my hands here rather than my body so that you can see. So in this position here, are we relaxed? And we're just going to take from that midline position, we move the tibia that way. I don't know whether you can see, but there is some movement there.
Are you moving that ankle towards you?
Yes.
Yeah.
So I'm trying to fix the femur so it doesn't move, and then the tibia, I just move the ankle literally towards me. There is some movement, I don't know whether you can see that. Actually, that movement's not bad. You would expect some movement, absolutely. So there is not much laxity in a medial ligament there. Let's have a look at the lateral ligament now, where we do exactly the opposite. And now we're going to take the ankle away from me, so we're going here. Can you see the movement there? There should be more movement going across, that's normal. So we wouldn't say that's particularly lax. And the key thing here is that when you get to the end of the range of movement of the ligament, you can feel a physical block. The ligament is stopping you from going further. If you've damaged the ligament and it's very lax, or indeed it's ruptured, you can literally, I'm not going to do this, you can literally get rid of the tibia and you can just keep going. It's almost a scary feeling, if you see what I mean. But here, when we're looking at Fiona's knee, we're here, medial ligament is intact, it's not lax, and the lateral ligament is looser, but it should be looser, so mechanically, we're good. You're all right. We'll do your cruciates later. Thank you very much. Does that make sense? Yeah, because...
So, like you said 15% sort of like movement is normal or not?
it's about 15 degrees flexion of the knee, so that you've got the right angle. It's actually difficult to put a number on it, to be perfectly honest. It's very subjective. There's a piece of equipment called a KT1000 which will actually measure that, particularly the cruciate ligament movements, quite well.
Tension kicks in then.
Yeah, it's a very subjective thing. Once you've done a few normals, it's really, really obvious. But the key thing is not so much the amount of movement, but it's more the feel at the end. If you feel as though you can keep going,
right, okay,
they've got a problem. If you get to the end of that movement and it's absolutely fixed, and there is a physical block, that's great. It means the ligament is still intact.
What if there isn't hardly any movement at all? You can't. Is that a bad thing or good thing? You can't. There's no movement.
In 30 years, and I know I don't look old enough, but in 30 years, I've never seen that.
Right.
So
and are you looking for an equal amount of range of movement on both sides?
You would expect. You mean left to right?
Yeah.
Yes. Yes. I say that with some hesitation. Because mechanically different types of knee joints will present in different ways, but more or less, yes. If one side is appreciably more, then there's a good chance that that's the side that's deficient and is the laxer of the ligaments.
Okay, but what we're really looking for is a bit of movement and suddenly to stop.
Yes,
right.
Yeah, that's key. If it does not stop, then your exercise prescription needs to bear that in mind, and the exercises need to reflect that. Does that make sense? Yeah. Okay, so that's the MCL, that's the test. Well, actually it's the LCL, the lateral ligament test as well. So which muscles down the inside of the knee, that medial compartment, are going to help stabilise that medial ligament if that medial ligament is lax? You can shout the anatomy out anytime you like. Which of the ligament, or the tendons, I'm sorry, that go down the inside of that knee that will stabilise the medial compartment? We've got it all filled in for you, we just don't have the names. Sorry?
Meniscus?
The meniscus, the deep fibres of the medial ligament are attached to the meniscus. So if you damage one, there's a good chance you're going to damage the other. But I'm looking for the name of the tendons that run down the inside of the knee, which sit on the end of muscles, hopefully. Iliotibial band is the other side. We're going to talk about that in just a moment. You're one step ahead of me, as always. The what, sorry? Yeah, one of the adductors. Which one of the adductors? Sartorius definitely comes down into here. Sartorius is one of the adductors. Did somebody shout gracilis? Gracilis, yeah, somebody shouted gracilis. We've got another one. Sorry. Someone shouted something else out. It doesn't actually go down below the knee, it stops above the knee. We've got another one. What about the hamstrings? There's a hamstring or two.
Semitendinosus.
Right, semitendinosus in particular. So we've got sartorius, you're quite right, gracilis, we've got semiten. Do you know what they're called collectively? Yes, yes. I got some of those in here as well. I think that cream we got outside. But what's the technical name for that? You'll kick yourselves because you know. Pezantherinus. Yeah. So when we look at that in real life, so to speak, this is what the tendons actually look like. Do you notice on the inside here there's a tendon here that hasn't been highlighted or been marked? And actually it's on this one as well that hasn't been marked. Do you know what that one might be? It's another one of the hamstrings. Semimembranosus. I was taught when I went to college that semimembranosus, went down the back of the knee. So as you can see, I didn't get any art qualifications. Semimem came down the back, went down the semimembranosus groove. We had a rock band in our college called semimembranosus groove. And it then went up and blended with the back of the capsule. And it does, but additionally, there is a slip that goes down. Sorry. Won't go the wrong way. Put that down so I can't push it in my pocket. So there is also, semimembranosus also has a slip. It's not officially regarded as one of Pezantherinus, but it's there. So what we need to think about is what exercises we can do to engage these muscles. Because if we engage these muscles, there's a good chance that they will have then the capacity to engage when we're doing functional movement. We might want to isolate them first to make sure they have the capacity to engage, but once they have the capacity, we're then thinking about functional patterns. So which exercises would you do to hit sartorius? I went online to look at some videos for this, by the way. You would not believe the shocking exercises you see on YouTube. Well, you probably would. Sorry, Lee.
Sort of like this sort of movement, sort of can you heal up?
Exactly right. Were you going to say something as well?
Yeah, I was similar with that.
Yeah. Sartorius, do you know its actions? Taylor's muscle, right. So if you were to sit in this, I can't actually do it, but if you were to sit in this sort of position, sartorius is the muscle that would get you there. So it's a hip abductor, external rotator, flexor, and it'll also flex the knee. So how might you create an exercise to hit all the different components of sartorius? What sort of exercise might you be thinking of? An exercise that would take you from this position to the one you just talked about, right? So you might have somebody with a band, they might be lying on the back, you might have a band tied around their foot, and you might be doing this type of activity. Yeah, you get some funny looks in the gym, but we don't care. Nothing new there. So something like this. I couldn't get a sartorius exercise online, and didn't have time to video any myself. So you've got hip and knee flexion, but you might take that leg into external rotation and abduction as you're doing it, and we're hitting sartorius.
So what you mean you bring in the heel towards the midline as you bring the knee up?
Yes, so you're trying to do that sort of position. Make sense? Okay, gracilis, what are we thinking about? There's a little clue. How might we hit gracilis? It's one of the adductor muscles of the hip. So it's a fair bet we're going to be wanting to do adduction, right? What will it do over the knee? What action will it have over the knee? Will it be an extender or a flexor?
Flexion.
Right. So somehow we've got to try and find a way of adducting the hip and flexing the knee at the same time. So we'll know about adduction. If you had a lax medial ligament, would you have the band down here? Or the fixation point down here? Probably not. Where would you have it? Probably above the knee, absolutely. So somehow you'd find a way of adducting the hip, offering a resistance to that. But additionally, we might try and find a way of flexing the knee at the same time. So hip adduction and knee flexion at the same time. And you guys can be creative about how you might create that using rubber bands and all this fancy stuff. But it's a combined component of hip adduction and knee flexion is a great way of hitting the gracilis. That's what it does. Any questions on that one? Semitendinosis. What are its actions? What does semitend do?
Flexion of the knee.
Yeah, it's a good start.
Extension of the hip.
Extension of the hip. It'll rotate.
when the knee's bent.
Yes. Yeah. Will it rotate the tibia medially or laterally?
Medially.
Yeah. Perfect. Perfect. So what sort of exercises might we do that's going to hit knee flexion and hip extension to hit semitendinosis? Yeah. Yeah, all of that. I know what you meant. You guys will be familiar with this type of activity. I'm not going to patronise you and show you a lot of hip extension, knee flexion exercises, but you know this kind of stuff. He's not going from a lot of hip flexion to a lot of hip extension. We'd probably change that to make sure he did if we wanted to make sure we're hitting both those components. But we would go in doing something like that and variations on that theme. But you can use pulleys and rubber bands, and obviously you guys can be really creative in terms of how you do that. And then once they have the capacity to engage, once we know those muscles are engages and they're firing in an appropriate way, then of course we want to try and be functional. Those S&C guys amongst you are familiar with the sort of triple extension patterns of the lower limb. So you've got ankle extension, knee extension, hip extension. Try and understand what their sports are, what their activities are, and then provide them with patterning exercises that mimic those sports based on these sort of principles. So try to look at the relevant triple extension patterns to teach the neuromuscular system to reflexly engage the appropriate muscles. One of the problems is if we go straight into functional training, in my experience, if muscles aren't able to engage, then the body will just compensate for that. So if you've got a gracilis that isn't firing for whatever mechanical reason, and then you ask it to do a functional exercise, it probably will continue not to fire. The other guys will have to do more work, and we're basically learning it wrong. This is a concern. We need to do a period of time, not long. I think it's Mel Siff talked about you can do non-functional training up to 6 weeks without having a negative impact on performance. So we probably don't need to do any more than 2 or 3 weeks to make sure a muscle is engaging in a proper way, and then we can go into the functional side of things. So if there's any concern about whether the ability of these muscles that we've just talked about to engage, then spend a few weeks just firing up specifically, locally, in an isolated fashion, which I know is not trendy these days, but we don't care, and then start going into the functional stuff afterwards. Okay. Any questions on the MCL? Fairly straightforward? Cool. Lateral ligament. We've done the screen. It's the same but opposite. Remember, we're going to take the leg into that varus position. The lateral ligament is more like I expected the medial ligament to be. It's more of a finger-like protrusion. And if you look at that's the femur, that's the tib, that's the lateral ligament in here. And it's really easy to find. If you cross your leg over, I'll try to do it. If you find the joint line and let your leg drop down, there's like a thick band that sticks out right on the outside of the joint. It's relatively easy to find. It also tends to attach to the lateral meniscus, not so much as the medial meniscus and the medial ligament, but it tends to attach onto that lateral meniscus there as well. Most structures tend to attach together. It's been shown quite well more recently that structures are not independent, they're all related to some degree, if not physically attached. So the screen we've done, so we're not going to go through that again, go away. And then, so the muscles that run down the outside of the knee, which ones particularly are we interested in to try and stabilise and support that lateral ligament? Iliotibial band, well done. Another one?
Meniscus lateralis.
Sorry, I can't.
Vastus
Vastus lateralis is more on the anterior side, and it tends to go around, it blends around with the patella with the others. I'm thinking about something more posterior. Another one of the hamstrings?
Bicep femoris.
Biceps fem, absolutely. So if we can figure out exercises, if that lateral ligament is loose, if it's lax, if we can figure out exercises to hit the iliotibial band, and we'll talk about that in a bit more detail in a second, and biceps fem, there's a good chance we'll be able to locally stabilise the lateral component of the knee. So biceps fem comes to the ischiotuberosity, down into the lateral part, lateral head of the fib, and also the lateral tibial condyle. But there's two parts to remember. We've got the part of the long head here, and we've got the shorter head here that comes from the back of the tib. Sorry, back of the tib. Anatomy never was very clever. Back of the femur. So, if we're looking at strengthening or working the hamstring, how do you think we might be able to position the leg, the hip in particular, to try and emphasise the long head and the short head? Bear in mind Astram's principle that the longer a muscle, the greater its potential force of contraction, without going to an extreme.
Which you abduct the leg, the long head.
Abduct it, did you say?
Yeah. Sorry to say abduct it.
Abducting it will probably lengthen it, probably. How might be an easier, more obvious way of lengthening it? Right, so what position would the hip need to be in to stretch it? Right, flexion, yeah. So you take the hip into flexion, maybe a little bit of abduction as well, and then do leg curl type activities. That's very likely to engage, as well as other muscles of course, very likely to engage the longer head. If you wanted to take the longer head out, obviously you can't do that literally, but take the emphasis off that. How would you change the hip position to put it more on the short head? Right, put it into an extended position, so shorten it, so it's more difficult for that muscle to engage. Yeah. We'll look into more of that if you Google active and passive insufficiency of two joint muscles. That's something that you might find interesting, and you can start to play that into your exercise prescription, especially with the two joint muscles. So from an exercise point of view, we've just covered the basics there. So we're looking at both knee flexion with the hip inflection and with the hip in extension. Yeah. There's a theory, and it probably is only a theory unless you guys know of more research than I, that by taking the tibia into a slightly more lateral rotated position or medial rotated position, it might give it the biceps fem more of a mechanical advantage to engage. But it's just a thing. But it's worth having a look at, because that might have something to it. Iliotibial band, or Maciat's band, as it's also known, although not commonly. Superior fibres, superficial fibres of gluteus maximus combine with TFL to form the iliotibial band. Do you know what the function of those two muscles and the iliotibial band is? What's its primary function? What's the point of those structures being engaged together? Stabilise the hip and to stabilise the knee at the same time. Absolutely. So when you take weight through that leg, not only do you want that knee to be stable, which the ITB helps with, but at exactly the same time the hip needs to be stable as well. So by engaging one set of muscles, you're engaging both the knee, stabilising or helping to stabilise both the knee and the hip at the same time. So that's exactly right. So if we wanted to try and engage this whole group of structures, what sort of exercises would we be thinking of?
Single leg motion.
Single leg?
So single leg like posterior slings of motion, so weight shifting from one side to the
Sort
other.
of lateral type movements? Yeah. Sorry?
Sort of, I know it inserts into the fascia glute mat, but single leg work that stimulated glute med, almost, you know, that kind of.
Yeah, it's going to hit them as well, I agree, absolutely. Perfect. What's a great functional exercise to engage these muscles? That's a great functional exercise, isn't it? Being a bit more specific to these structures. Bear in mind that when you take weight through the leg, one of the shock absorbing features that we have is the ability, of course, we pronate the foot, we flex the ankle, we flex the knee, and we drop the hip. So dropping that hip is a relatively functional task. That's the only clue you're going to get. Jumping, hopping, all that kind of stuff, absolutely on single leg, because we're engaging those muscles to stabilise. But bring it back a couple of paces. How might we start? Before we start doing the high velocity stuff? Yeah, the hip hitching type exercises. And I need a bit of assistance. But doing this type of activity, to start to engage those hip abductors in a relatively functional way, is a really powerful way of starting to engage those muscles. We did a little bit of, I think the best description is tin pot research. We had an isokinetic machine and we tested it hip abduction at 30 degrees per second. We got 60 guys. We tested it at 30 degrees per second and looked at their hip abductor power. And then we split them into different groups. Some of those guys we sent away to do 6 weeks worth of hip abduction on a machine, you know, the sort of clam type exercise. We sent another lot away to do, on the hip machine where you're sort of doing single leg abduction, and we got another group to do this. The group that did that were 40%, on average 40% stronger, generating 40% more force on the isokinetic machine after doing that exercise than the stuff on the weights. It's quite interesting. Yeah. Okay, we didn't publish, it's just a little pilot that we did just for our own interest, but I'm just sharing it with you. So, those are the sort of exercises that we might do. And this is a really, really bad example of what I've just described.
Why is it a really bad example?
So it's a good example.
Why?
His balance sucks, his shoulders are doing all this, his knees bending.
I can see it. It's twisted, yeah.
So we might want a bit better form, but actually, once he's got that form and once he's nailing that movement, we might ask him to bend the knee, because that's what he does when he runs, right, and when he walks. So we might ask him to bend the knee. We might ask him to rotate those shoulders so he learns to then control it. But to start with, we probably want a little bit more control. And then once we've done that, it's on the table. You guys know more exercises than I do, I'm sure, about which exercises we need to do to look at that triple extension pattern. I'm not sure how much you're going to be talking about triple extension stuff later, I don't know, but I know. But I don't do it. I felt like that about 10 minutes before I was about to talk. But yeah, that sort of squat type patterns, making it functional and relevant to whatever their tasks are going to be. What time do I need to finish?
How long should we give him? 5 minutes.
5 minutes, no problem at all. We'll bang these next one through. ACL. The PCL is going to follow. We'll email that to you. It's all on the presentation, but we'll just do the ACL because that's what it was. So the anatomy. We've covered it really. So we've taken the patella off. I say we. I've lifted it off the internet. They've taken the patella off. That's the anterior cruciate in here. There are a load of different tests to look at whether the anterior cruciate ligament is functional or not. whether it's able to limit that range, limit the movements. The pivot shift test you can look up. They're relatively difficult to do, so I'm not going to demonstrate that one. There's a much easier test to do called the Lachman's test. Basically, you have that knee at 20 to 30 degrees, and then you fix the femur, that's the tibia. That is a beautiful example of a lax anterior cruciate ligament. Who's got one? Come on, who's got one?
Me.
Who said me? Come on. Oh no, you're not doing it. Is your ACL alright, or is it? It's alright, but we don't want you to. We want a lax one. Anybody got a loose ACL? There must be somebody.
I've got loads of loose stuff. I don't know.
Come on then. Which one is it? I can't remember. Left. Yes, please, yeah. So, take time, by the way. So, excuse my back. In fact, actually, the other way around is probably going to be better for where you're sitting my back. Lie down, please. So the idea is you stick your leg underneath their femur, so that's nice and fixed and stable. Have your hand on the top of the patella here, so it's not over it, it's just above. Again, so you've locked in the femur here. You're making sure that they're relaxed. You get hold of the tibia here, and you move it forwards and backwards. And that's quite loose. Not as loose as that one, but it's quite loose. Thank you very much.
Mine's not a complete rupture. It's, I think I've got some little threads attached.
Yeah, you get about 30-40%. Gone are the days where you bust your ACL and you need surgery. Yeah, there's a lot of rehab. Rehab's improved so much now that sometimes you need it, sometimes you don't. It depends on how stable the capsule is as to whether you need to do it. If you bear in mind that at one time 25% of the All Blacks did not have anterior cruciate ligaments and they didn't need surgery. They got legs out here, which kind of helps, but you don't always need surgery. So that's a real simple test, Lachman's test, and you can find it online as an example. It's a relatively easy test to do, and again, it's yes, the amount of movement is relevant, and when you've done a few, you get a sense of what that movement is normally. But it's whether when you get to the end, is it soft and squashy, or is it what we call an end feel? In other words, you get to the end and it stays at the end, and you just can't keep going. That's quite important. Once you've done a few, you'll pick that up. So the whole purpose, if that's the cruciate ligament here, that's the femur, that's the patella, that's the tib. The whole purpose is if that cruciate ligament is longer, that tibia is going to likely translate anteriorly far more. And that's something we want to try and avoid. What structures in the knee are going to be loaded excessively if we've got this translation, exaggerated translation? You mentioned it earlier. Meniscus, yeah, meniscus, definitely. So, the ACL muscles, my terminology, not official terminology. In other words, which muscles might we be interested in engaging to make sure that that tibia was less likely of translating forwards? Specifically, there's a few on the back of the leg there. Which ones are we going to pick out? Which muscles are going to help stop the tibia from translating anterior? Which are going to pull it back? Hamstrings, yeah, absolutely. Any others? Gastroc, yeah, gastroc may as well. Yes, it may as well. There's conflicting evidence on that, or conflicting opinion, but I think it's very likely, to be honest. So what sort of exercises might we be interested in? You guys know 4,000 hamstring exercises and probably more calf exercises. Thinking about the progression of exercise that you're already familiar with, so just working through those groups. Trying to isolate, then integrate, and then, of course, to become functional, which is really where we need to be. Okay, I'm going to get dragged off in a minute. So, any questions on this stuff? Make sense? Yeah? Don't be afraid to do these tests. They are perceived as clinical tests, and therefore you're supposed to have your fingers burnt when you do them because you're not therapists. Well, if you're trying to diagnose and treat a medial ligament injury, then that might be right. But we're not trying to do that. We have no interest in that. What we're trying to do is identify whether that medial ligament, in this example, has the capacity to do what it's supposed to do. And you are well within your rights to do that. Absolutely no problem at all. If it is lax, it will absolutely influence your exercise prescription. You need to know whether it's lax or not. So do go in and do these tests and find
So
out.
you do the ligament dominance test, and these are the ones that you add onto the end of it.
Yes, indeed.
Right, okay, and then
Yeah.
that will more guide your exercise prescription.
Absolutely, absolutely.
To which, so that it is the knee function screens and allows us onto the end
Yeah,
of it.
yeah, yeah. So especially if they've had a history of problems, then you just do the test. Those tests would take you probably 30 seconds.
Yeah.
It's not a big ask time-wise, and that gives you more clues about how you can be specific with your programming.
Sometimes if somebody's got like knee problems or if they're quite elderly, they're very concerned about doing kind of like quad dominance tests.
Yes.
Yeah.
So would this be a better, would this be a better protocol to go
Yes,
down?
absolutely. In fact, I've just spent the last 2 days testing a load of seniors to look at, to do some research for a pharmaceutical company, to look at knee implants and hip implants and stuff. And I went through all the full sort of intrinsic biomechanical screen. I did ligament dominant test, but I did not do quad dominant and I did not do leg dominant.
Yeah.
I did these. We have to be sensible.
Would these tests, would you retest and would you expect to see an improvement?
No. No, it's very unlikely that the ligament test will improve because you're strengthening, wrong term, but working different muscle groups. It's very unlikely. What we're interested in is making sure those muscles can engage dynamically to dynamically stabilise what is a relatively unstable joint. But the instability, the passive instability, is unlikely to change.
So you're just looking to strengthen the muscles to improve the
Right.
stability.
Right, protect that vulnerable area, so to speak. Yeah. There is some evidence just come out of Scandinavia, probably 3 or 4 years ago, that said by doing this type of activity, it can thicken the ligaments around the knee, the capsule in particular, but whether you would see an obvious difference on a test like this is debatable. But we don't care. All we want to know is which exercises to give. Thanks a lot.